Okie dokie. So yeah, I was asked to talk about our results for action program, or the packages that we offer in terms of providing data, and just a little bit of a background in terms of where our data comes from and how we basically make it accessible. So obviously within South African public health sector, we have one sort of public sector laboratory service, the NHLS. All of the data, the test level data, comes through into various data warehouses, one of which is the surveillance data warehouse at the National Institute for Communicable Diseases. And we mine that data and make it accessible specifically for the pediatric HIV program to essentially support tracking and tracing of our patients, as well as to try and improve clinical outcomes. We also do provide aggregated reporting as well as dashboards that are accessible. But just to note that so the data that I'm providing this evening is all coming from the public health sector. I'm afraid I don't have access to private sector HIV laboratory data, so it is really restricted to the public health sector. So in terms of what I'm going to cover this evening, I'm going to cover the National Institute for Communicable Diseases HIV MNE menu, and go through the various reports and data that is accessible. And then I'm going to go through the self-service portal in terms of how you can actually access the data that you require if you do need data, whether that's patient identifying data or aggregated data or de-identified data. Then I'm going to go into the results for action reports, which are consolidated line lists of patients who require clinical action based on their laboratory results. I'm then going to pivot to looking at maternal HIV viral load monitoring, because there was a code that was introduced in 2019 in the public sector to try and support monitoring specifically the maternal HIV program. I'm then going to look at early infant diagnosis, just a little snapshot, as well as looking at the volumes of viral load testing and viral load suppression rates in the country. Okay, so just to begin with, and so I'm happy to make these slides available, because some of the slides you'll see have an embedded file, which includes a lot more detailed instructions in terms of and reporting structures or menu that we provide. So I'll make sure that this is accessible. But just to break down the type of reports that we have, so you can break it down in different ways. We've got sort of all ages or adult reports that includes an HIV MNE dashboard, and includes also results for action reports, which are broken down into particular test types. So an HIV viral load results for action report will include all high viral loads and rejections. The TLD transition report was to try and support the rollout of TLD identifying suppressed patients as opposed to non-suppressed patients who require transition at the early sort of time of rollout. There are other reports other than HIV. We do have cryptococcal antigen reports that we support. It's not directly coming from me. I'm not responsible for it, but we do support those reports. And then HIV ELISA reports. So that's the adult sort of reporting that we do. That's accessible through the self-service portal. We've also got the pediatric reports, and we've got some more than the adults, because we do focus on pediatric HIV surveillance. So we've got PCR facility reports, which is basically how many tests were done and how many were positive per age group per facility. That rolls up all the way to sub-district, district, and province. We've got a misdiagnostic opportunity report that is providing information in terms of all samples that didn't get verified with a positive or a negative. We refer to those as misdiagnostic opportunities, because the majority do require repeat testing either from a clinical reason, as an insufficient sample was taken, or a logistical reason, sample didn't arrive in the lab. So that's what MDO stands for. And then we've also got the results for action, but specifically for PEDS, obviously looking at the PCR results for action, that would be positive, indeterminate, and rejections. And then a pediatric and adolescent viral load with a CD4 component, so high viral loads as well as low CD4s in that report for children and adolescents less than 19, and then HIV ELISA as well. And then we have a host of other materials that are accessible, including monthly reports looking at age disaggregated viral load testing and suppression rates at national, provincial, district level, looking at the maternal viral load EGK code, which is this marker of maternity, which I'll go into quite a bit more detail, and looking at early infant diagnosis. And we provide these to the field on a monthly basis. We also provide a monthly maternal viral load EGK report at facility level, so that facilities can monitor the uptake of this very important code for maternity. We also have dossiers that provide the UNAIDS cascades, the 95, 95, 95 targets. And then we also support ad hoc reporting. And I'll provide my contact details at the end as well, but essentially we're here to support the field with data, if that's identified data or non-identified data, depending on the needs in the field. And you can always contact us at hiv@nicd.ac.za should you require any information or clarity, and I'll provide my details at the end as well. So that's one way of breaking down our reports in terms of age groups. We can also, very importantly, and need to sort of highlight the difference between patient identifying data, which will be above the red line here, and de-identified data, which will be below the red line. And essentially the importance of providing identifying data is that we need to ensure that we work within the appropriate legislative framework, specifically the Protection of Personal Information Act. And I'm going to go through the POPI Act in quite a bit more detail, just so that we are all sort of understanding what the implications are with personal identifiers. There's been a lot of concern and apprehension because of the POPI Act, and essentially I just want to highlight the importance of, if you are accessing patient identifying or personal information, how to basically use that data in a responsible and legal manner. Okay, so starting off with a bit of the sort of let's say the details in terms of how to register these reports and how to access them. I don't want to go into too much detail, but I think that it's a helpful platform I've got here to let's say highlight how people or people in the field can actually access these various reports. So the first step, if you want to register for data from the NICD, the first step would be to register on the self-service portal. Website is quite simple. It's www.nicd.ac.za. If you click on the M&E dashboard, you'll see that the surveillance pop-up screen will appear. And if you haven't registered before for any of our NICD reports, you simply click or select guest login, select self-service registration, and then register as a new user. And again, the sort of information is attached in the PDF on these slides. Once you select sort of new user registration, in red, another screen will appear, self-service portal screen will appear, and you simply select or provide us with your details. Very importantly, you need to agree to the terms and conditions and the user privacy policy, which has recently been updated. And there's a POPI Act training video that is required viewing prior to registration. And then you submit, and we'll have you sort of vetted. We'll go through the details that you provide on the self-service portal, and then hopefully we'll sort of register you. And if you have any challenges, again, here's our email address, hiv@nicd.ac.za. The next step is you've registered, that's great, but then you actually need to select the various reports that you like. And this is specifically for any patient identifying data, you need to select the reports yourself. We won't provide any patient identifying data unless you go onto the portal and have been registered. So you select sort of add report, you'll punch in your ID number or passport, and then run the document. That ID number or passport is what you've just registered with. And then you'll see your details should come up. And very importantly, you can add reports at a facility level, at a district level, or even at a provincial level, as long as it's not identified data. Patient identification data is only accessible at facility and district level. These reports are also importantly available. You can choose whether you want to access the report on a daily or a weekly basis. Okay, so again, results for action reports or RFA, they can be accessed at a facility level or at a district level. You get to choose, and you can have access to them on a daily basis or on a weekly basis. Again, you choose, and how the selection criteria works is you choose the overall category. Is it an all ages or adult report that you want, or a pediatric report? You choose the report type. This is usually a test type like a viral load or a PCR. You select whether you want the report on a daily or a weekly basis, and then select the province, district, and if you are selecting for a facility level report, the individual facility or facilities, you can select more than one. Okay, and then you submit that, and hopefully within 48 hours, we will register you once we've confirmed your details and sort of check with your request. Okay, so that is the actual sort of steps to register. Now going into the actual reports. So as I've mentioned, these reports can be broken down into the various test types, and the main three reports are the viral load reports. That's an all ages report, and that will include all of your viral loads greater than 1,000, as well as low level viremia between 50 and 999, and all the rejections for that past week or that past day, depending on what you've chosen. There's a PCR report, which includes the positive indeterminates and rejections, and then, as I've indicated, there's the PEDS viral load and CD4 report. How you access your reports, we'll send you a reminder every week about these reports. In the reminder, it will give you instructions in terms of how to access the report. You go onto the NICD website, you click on the M&E dashboard. Now you've got a username and password, you fill that in and you log in, and then you select RFA portal. There's also a link embedded in this email directly, and you can just double click on the link if you want. And there's also a user guide, as well as a POPI Act compliance checklist in a file attached to this email that you can go through, and that's intended to support usage as well as POPI Act compliance, which I'll go through just now. Okay, once you go onto the portal, you'll see a screen whereby all of the results for action reports that you're registered for will appear. And this is just a screen for my results for action reports that I'm registered for. You select an individual report one at a time, and then you download the report. And essentially, you'll be downloading a consolidated line list in Excel of all of the results that require action. If you want a report for the last couple of months, you can run an ad hoc report. So this is the current report, but we do have an ad hoc report option. So if you missed a report, you can go back and hopefully find it. I think we've given two months in the past to run an ad hoc report. And then if you want to brush up in terms of POPI Act or terms and conditions, we have a training video as well embedded there. Okay, once you run your report, as I mentioned, an Excel document will be downloaded, and I'm going to touch on this just now in terms of what the Excel document looks like and how to manipulate it. So I'm going to go out of my my slideshow and open up this Excel document. Maybe Liseko, can you just confirm that you can see this Excel document?
Yep, we can see it.
Right.
Thank you.
Okie dokie. So just to orientate you, there's four sheets at the bottom. There's a terms and conditions sheet, which is essentially the same terms and conditions which you will sign up to and agree to on registration. There's a cover page, which this is an example of an all ages viral load report. The cover page will give you a bit of details in terms of how to interpret the information, when the report was run at the top, which report it is, of course, the district or the facility of which it belongs to, and some summary stats. This report was run a while ago, and the reason I'm presenting it is because I've removed all the patient identifying information from it just for training purposes. So that's the cover page. The next sheet is actually the results for action, and I'm going to click on that here. And you'll notice that essentially this is a consolidated list of all the patients who have high viral loads and rejections that require action. All of the X's are where we've removed the patient identifying information. So this report is from Etequini, so obviously it's from KZN. There's the district, the sub-district is provided, and then the facilities and the wards as provided on the form. You'll notice that quite a few of the PHCs don't actually have a ward, which is slightly unfortunate and speaks to data quality issues, where it would be extremely helpful if wards can be provided or clinic names can be provided. The folder number, this is also very poorly populated. You'll see if you subscribe to these reports, in some regions of the country, it's really it's very poor. Although folder number is one of the minimum clinical data sets within the NHLS, often testing is performed where there is no folder number. Sometimes dates of birth are obviously used, which are better than nothing, but again, not ideal. Patient surname, patient's first name, date of birth, the sex of the patient, their address and telephone number. Where there's blanks, nothing was provided. So you can see that there's obviously a whole host of gaps here. The addresses and telephone numbers can be really helpful in terms of identifying these patients and bringing them into care if they need so. Age is calculated by date of birth, the taken date, the review date. The episode number is the lab number. And then this is quite an important number. It's the CDW patient identifier. That stands for the corporate data warehouse identifier. We don't have an operational unique patient identifier in the country yet. We obviously are aware that there's a lot of work on the health patient registration system, the health patient registration number. But currently, we don't have a way of linking all test results to a given patient. So what we've been doing for the time being is using an algorithm that links results based on the patient's demographic data. That's specifically the first name, their surname, their folder number, their date of birth. And if they're exactly the same, the algorithm will link them together. It obviously will underlink rather than overlink based on the sort of potential for transcription errors, spelling errors, and the like. But we've tried to support getting actual patient level views on the test level results. And how we've used that or leveraged it is to try and see if a patient has a high viral load, have they previously had high viral loads? And you'll see the last column on this page, there's the total number of previous consecutive viral loads greater than 1,000. So what that means is this patient in the row I'm highlighting, the second patient here, their current viral load looks like is at 1.6 million, but they've had 2 previous consecutive viral loads. So the likelihood is that this patient is actually failing, virologically speaking. And we've provided, I can see that. We've provided where you can actually view those previous results on the last sheet. So the previous viral load greater than 1,000, you'll see where those results were taken, what those results were, and when they were taken as well. And that's what this last sheet is, the previous viral loads greater than 1,000, to try and help and assist with retrieving those results and ensuring that patient is appropriately managed. And to be able to do that, we've used the CDW patient identifier to link. So again, it's not perfect. It tends to underlink rather than overlink, but occasionally it does overlink. I mean, for instance, you'll see that this patient over here, their current viral load is, it looks like 1.4 million, but they've had 7 previous consecutively high viral loads. I'm not going to remove the identifications of this, but obviously, if you did so, it would be very interesting to see where this patient actually was being tested. And the nice thing about using the NHLS data is it's got a national footprint. So if the patient's demographics stay the same across the facilities, you'll be able to see where this patient was seen, regardless of whether it was in a different sort of facility or even district or province. So that, hopefully I've explained what that last column is. The actual results column stands to reason. So red is all viral loads that are greater than 1,000, high level viremia, and then amber is all low level viremia between 50 and 999. And then if you go underneath, we've also included all of the rejections, including the reasons for rejections, and that's to try and help bringing those patients back in and repeat testing, because most rejections, those patients do require repeat testing. Occasionally, there will be a reason why you wouldn't want to repeat the test, such as duplicate samples or duplicate registration. But unsuitable hemolyzed, that specimen needs to be repeatedly taken. Specimen not labeled, that needs to be repeated. Failed after repeat attempts, so essentially that's an invalid result. It needs to be repeated. Okay, so that is that component. The last column I want to go into a bit more detail is this maternity EGK group. So yeah, I'm going to before I get there, I'm going to cover what that actually stands for. So EGK is electronic gatekeeping. It's essentially a cost-saving mechanism that NHLS supports on instruction by the Department of Health, so that unnecessary testing is not performed. And there's certain rules. So for example, usually viral loads won't need to be repeated within a 3-month period. So there is a rule that's set that if a patient has another viral load request within 3 months of their last viral load, there would be an automatic rejection unless there's a bypass code. Okay, and those bypass codes are available, and I'm going to touch on those just now. So essentially, yeah, for maternal viral loads, there was this electronic gatekeeping system which was already in play. In the 2019 clinical guidelines, there was an update in those guidelines whereby all HIV-infected women at time of delivery were recommended to have a viral load test, irrespective of when their previous viral load test was done. So obviously now there's a conflict between the guidelines, which say every single HIV-infected woman in South Africa should have a viral load at time of delivery, regardless of when her previous viral load was done, and this EGK rule. So essentially, they needed to introduce a system whereby these maternal viral loads, which were being done over and above usual care, would not be automatically rejected. And so they needed to create these electronic gatekeeping rules to bypass the rejection. At that time point, obviously, there was also the realization that, we don't have a marker of maternity within our healthcare system. And it's essential that we try and support, obviously, maternal care, as well as the elimination of vertical transmission from mother to child. So there was basically the opportunity was taken to leverage these codes. If the codes are being put on the forms and they're being captured, then we actually can leverage that as a marker of maternity. And if it's being used effectively, we can then monitor the uptake of viral load testing at time of delivery, as well as monitor maternal suppression. And that's the background but behind these codes that were specifically introduced for maternity, the maternal EGK codes. So they were introduced in 2019 primarily to prevent sample rejection, but also then to allow patients to be traced using the RFA reports and to monitor the maternal program. So hopefully, if you're working in the public sector, you're familiar with these codes. There were two codes that were introduced in 2019. I'm going to put my pointer on. There was a CH PMTCT code, which should be put on all NHLS request forms at time of during the antenatal period or during the breastfeeding period. So antenatal or breastfeeding, you use the same code, CH PMTCT, and you're expected to write it on the request forms. And here there's a little bit of a snag because some of the request forms, especially at clinic level, do have an EGK approval code space, but some of the older forms don't. And then the recommendation is just to write it, for instance, on space that is available on the form, such as under address, which is not, you don't normally need all 3 rows. And then the other code is the CH delivery code, which is just to be used at time of delivery. And there's some limitations with just using 2 codes because we want to monitor, the viral load uptake and suppression antenatally at time of delivery, but then postnatally. And how we thought this was going to happen was if the CH PMTCT code is used postnatally and the patients had a prior CH delivery code, then you can categorize it as postnatal. So 2 codes were thought to simplify the process, and then in the background in the warehouse, we would then categorize these as antenatal delivery and postnatal. And I'd be very interested to hear from the participants who are working in the public sector if they are familiar with these codes. The important part is these codes now need to be used every single time a pregnant or breastfeeding patient has a viral load, regardless of whether that specimen would have been rejected by EGK rules or not, because now it's being leveraged as a marker of maternity. Okay, so I'm gonna go back to this results for action report, and hopefully it's going to open up again. And I'm going to go and manipulate it a little bit so that everyone is just familiar with Excel and how to actually use it. So I think, yeah, I'm going to go from very basics, and please excuse me, all of those people who are proficient in Excel, but I found that a lot of our potential users are not. So within the 3rd sheet of the viral load results for action sheet, it can be quite helpful to apply a filter to Excel. To apply a filter, you'll hover. So if you follow my mouse to the top left hand of the screen, you'll see the first row is numbered 1. And where my mouse is, there's a black arrow. If you left click on your mouse on the first row, you'll see that you'll highlight all of the column headers which are positioned in the first row. And then you can apply a filter by going to the top right of the screen. You apply sort and filter. You apply a filter on the drop down, and then you'll see these little drop down arrows on all of the column headers. And if, for instance, you are particularly, let's say your role is to follow up all maternal patients in your district or facility, you can then select all of the viral loads that require action for your pregnant and breastfeeding patients by simply deselecting the blanks. And then all of the patients with these EGK codes will come up. So here essentially is your list of pregnant and breastfeeding patients for the last week where they had a viral load that was above 50. And you can see where they are, whether they're antenatal, delivery, postnatal. Other is because sometimes we get codes which don't fit the 2 approved codes. We get sometimes C# labor or C# maternity. We know you're trying to tell us something, so we've categorized them as other, as in they are maternal patients, but we don't quite know where they are in terms of whether they're antenatal at time of delivery or postnatal. And so here you can see patients who are sort of unsuppressed during the antenatal period, but a few of them haven't been suppressed for a while. And obviously, if we are serious in terms of eliminating vertical transmission and improving outcomes amongst our maternal patients, we need to ensure that those patients are brought into care and appropriate management is provided. So that's basically, yeah, a very quick crash course in terms of Excel manipulating the results for action. You can obviously select any other groups if you're tasked with supporting adolescent boys and young men. You can select males, and then you can select age groups as well. Similarly for women living with HIV or adolescent girls and young women. It's obviously very much dependent on the data quality that is provided on the NHLS request forms and captured within the laboratory information system. And I think I just want to highlight that if the codes, the EGK codes aren't being utilized, obviously, then we don't really have a handle in terms of maternal virological monitoring. Okay, the other thing that I think is very obvious to everyone here is that this is extremely sensitive information that we are providing in these Excel spreadsheets. Now, the server, the NICD server is secure. You are, accessing the data via a secure server, but once you download that data, we obviously, as NICD, we don't have we don't have, let's say, an oversight of what you're doing with your Excel document. And that's why it's really essential that everyone who is accessing this data understands the legal framework within which that they must sort of work within, specifically with regards to the Protection of Personal Information Act. So the terms and conditions that you're going to sign up for on registration are essentially the POPI Act requirements in terms of dealing with patient identifying data. It's quite a lot of legal jargon, and to try and support the responsible and legal utilization of the data that we're providing, we've made a POPI Act compliance checklist, and I'm going to go through this checklist. And the idea we've done this checklist is if you adhere to this checklist, we believe that you will be on the right side of the law, and that you can and should be using this data. And obviously, if you're not, then essentially you are need to take responsibility for that. So I'm going to go through this checklist one by one. So number one is in terms of accessing the data. You obviously shouldn't be sharing your password with anyone, and you should only be accessing the reports that you require. Number two is in terms of storing of the data. You can save the data, but if you're saving the data, it obviously needs to be password protected with a unique password. If you are printing the data, as in you want to print it out, you can also do that, but you then must ensure that the data is kept in a secure and lockable location. In terms of the use of the report, we've had quite extensive legal consultations, and essentially the personal identifying data that we provide can and should only be used for tracking and treating individual patients. It's not to be used for statistical sort of epidemiological research purposes. It's to improve patient management. We are making these results accessible because we believe that this data needs to be available to healthcare workers in the field to try and identify patients who require urgent action, bring them into care, and provide the necessary clinical care based on their results. On that next point in terms of utilizing the reports is if there are inaccuracies in the data, then there is a responsibility to inform us, and you can inform us via our email address. In terms of sharing of the data and sharing of the reports, that you can share the data with other healthcare workers who require the information to track and treat individuals, but only the amount of data that is required by that individual. Essentially, there is a principle within the POPI Act that you should not be accessing personal identifying information unless you need it. So if an individual is only sort of working in one particular facility, you should only give them data for that particular facility. You shouldn't give them excess data that they don't need to fulfill their duties. You can email the data to other healthcare workers according to the POPI Act, but there are important sort of requirements to that end. The data must be password protected. You can share the password, but in a separate form of communication than what you've just emailed the data. So you shouldn't be emailing personal identifying data that's password protected with the password in that same email. You should send it as a separate email or send it as a message or a WhatsApp, just so that the password and the file aren't together at the same point in time. If you are emailing someone, you need to make sure also that their email address or server is based in South Africa. So you can't email data outside of the country. So you shouldn't be emailing any personal email accounts like a Yahoo account or a Gmail account or a Hotmail account unless you know that that server is sitting in South Africa. Otherwise, it's a cross-border transfer of data. You can, as I've mentioned, print out these results for action reports, but you need to ensure that they're in a secure envelope and not visible during transportation. And then in terms of sort of deleting of reports, you need to delete any personal identifying data that you no longer need. If you finish with the data, you need to remove it, either delete it on the file or actually destroy the hard copy. You should only have access to personal identifying data that you actually currently need. And then if you believe that there's been a breach of information, you are to notify us within 72 hours, whether that's you think your password's been sort of obtained by someone else, or if you think that you have had your electronic copy stolen. And yeah, I've already indicated that there is a POPI Act compliance training video on our website. And if you have any queries, please contact us. Okay, so that's the POPI Act. Hopefully, I've sort of alleviated any concerns from any people who that you may have in terms of dealing with this personal information. We strongly believe that if you follow those steps, that you will be within your rights to utilize the data. Okay, so that's the personal identifying information. Now I want to go into, I've gone from sort of individual patient information, and now I'm going to go into a bit more of the reporting that we provide. So we can obviously use these codes, these EGK codes, to monitor viral load uptake and suppression. And in terms of looking at uptake, we can use various other denominators within our health information systems, like the DHIS data, live births to HIV positive women. That should sort of resemble our denominator of all the maternal viral loads that should be done at time of delivery. It's not 100%, but it's a good proxy. So that's what we are. I'm going to show you now. In terms of antenatal, there's a few other indicators in DHIS, like the antenatal already on ART at first visit, and the antenatal start on ART, and if you just sum those, you can get a denominator for the volume of viral load testing that should be done during the antenatal period. Again, it's a proxy, it's not exact, but it's a pretty good proxy, we believe. So this is what's been happening with the EGK code uptake in South Africa. So the guidelines changed at the end of 2019, and obviously there was minimal utilization of these codes. This is just looking at the C-hash delivery code. And obviously there was a pandemic that started soon after, and all the lockdowns associated with that. So this is the trajectory that we've been having in terms of the percentage uptake of the C-hash delivery code over the number of live births to HIV positive women. It's been really slow going, but we're sitting at as of Q4 2022, that's calendar quarter, we're just sitting at around over a quarter of all of the maternal viral loads that should have been done were done with this code. And it is going in the right direction. It's been slow going, and we've been trying to support the field in terms of identifying where the gaps are, because there's potentially 3 reasons why we're not getting the codes. The first reason is viral loads are simply not being done as per guidelines, and I believe that is one of the bigger gaps that we are facing. The second gap is that viral loads are done, but the code isn't being put on the request form. And then the third potential gap is the viral load is done, the code is on the form, but the NHLS is failing to capture. And there's definitely a combination of all 3 gaps. We've been trying to monitor and support the field with this, but essentially, if these codes and this marker of maternity is actually going to be effectively implemented, we obviously need a broad-based buy-in from healthcare workers and laboratory staff to ensure that the code is a success. So that's at the national level. We can break it down at provincial level and see where we are with the code's uptake as well as suppression. So these blue bars are looking at the actual uptake of the code. So Western Cape about 76%, and then it goes all the way down. Limpopo only 5% usage, and Northern Cape 1.9%. This is for the period of July through to September last year. And then we can also have a look at the viral load suppression rates, whether that's suppression at the less than 1,000 cutoff or suppression at the less than 50. Obviously, we define suppression differently. So UNAIDS targets are defined at less than 1,000. Our clinical guidelines define suppression at less than 50. So we generally like providing both. Now, the one concern that we have is if the uptake is really low on these codes, it may be that obviously this is not necessarily representative data when you start looking at the suppression rates. But because I've aggregated it for quite a broad period of time, and this is at provincial level, I think that this is probably fairly representative of the actual maternal program. So I'm saying that in the Western Cape, around 87% of patients at time of delivery had a viral load of less than 1,000, but only 77 or 78% have a viral load of less than 50. And then in Limpopo, it's only around 80% of maternal patients at time of delivery have a viral load of less than 1,000, and a lot more patients have low-level viremia with only 65%. Okay, so that is looking at the uptake per province and suppression rates. We can also support facility level uptake, and I think this is where we're trying to go in supporting the field, because if we can differentiate the first gap versus the second two gaps, and that is, are viral loads actually being done or not? I think that would be perhaps a first step in really improving this and improving maternal care, and also hopefully preventing mother-to-child transmission. And again, the blue bar here, this is now at facility level for some facilities in Tshwane. The blue bar represents the live births to HIV positive women. The amber represents viral loads being done in delivery wards, and we've mapped Tshwane with the district clinical specialist team. So all of the maternal labor wards, postnatal wards where maternal viral loads would be done have been coded in our data warehouse, and then we can categorize the viral loads being done from those wards. Not perfect, because we obviously do know some maternal viral loads will be done in casualties or potentially theatre, but it gives us a good indication that, for instance, at Dr. George Mukhari Hospital, for a 3-month period, September to November last year, there was quite a gap between what DHIS was saying in terms of live births to HIV positive women and the viral loads that should have been done at time of delivery. So there's at least some room for improvement at DGM. And then you can see that they're obviously just not utilizing the code very effectively, whether that's because the codes are not being on the form, or that they're not being captured by the NHLS, or it's almost certainly a mixture of both. But there's certainly room to improve viral load testing at least. Mamelodi Hospital, a bit of the opposite. Their DHIS indicator is clearly not very accurate. Their DHIS indicators generally under quantify rather than over. Same story for Colophon, but hopefully you get the idea that we can then see the most important gap: are viral loads actually being done according to guidelines or not? Tshwane has been really improving dramatically in terms of the utilization of these codes, because they see the benefit, not just in terms of the results for action reports. You can identify all your patients who are pregnant and breastfeeding using the RFAs, but also for monitoring purposes, both in terms of viral loads done and suppression rates. So this is the idea in terms of the national suppression rates. So this is South Africa in red. This is your this is quarterly suppression for 2022. So you can see overall in South Africa, at time of delivery, maternal suppression is around 88%. In KZN, it's quite a lot better. KZN obviously has a very robust healthcare HIV program, and their suppression rates are usually top or second top in terms of provincial. This is still obviously, we would like to get well above 95% as per UNAIDS target. So we've still got a lot to go in terms of our maternal care. And you'll note that in terms of the country, our overall suppression is around 91%. So essentially, our patients at time of delivery have a suppression rate quite a lot lower than the average within the HIV program. Okay, this is looking at suppression. Again, we can break it down per district. So we do this only if we aggregate, because the district utilization varies considerably. But you know, within a particular province like KZN, you still have a lot of variability in terms of your suppression rates. Okay. And so you can look at maternal suppression, obviously within like a geolocation lens, but you can also look at it by breaking it down by age group. And this is using just routine laboratory data. This confirms what various studies have reported, that essentially the younger the age of a pregnant patient, the less that they are suppressed. So you can see that this is for 2021. I've yet to do 2022, but we aggregated the whole of the year, looking at the delivery codes being captured, and then looked at the suppression rates. And you can see that amongst your adolescent girls, aged 15 to 19, who were pregnant at time of delivery, only 76% had a viral load of less than 1,000. Only 56% had a viral load of less than 50, and suppression rates increase with the incremental 5-year age group. So the older the pregnant patient, the more likely they are to be suppressed within our healthcare program. And although the adolescents comprise a much smaller volume of our patients, they are obviously at much higher risk for their outcomes, as well as vertical transmission of HIV. Okay. So I think I've got a little bit more time. I want to go into some of the other reporting that we do. So I've touched on the EGK in the viral, sorry, in the EGK and the RFAs. I'm going to exit this and go through to one of the other reports. So every month our team email out two reports. I mentioned them at the beginning of the talk. The one is the monthly maternal EGK report, and the other is referred to as an Operation Patuma report. So the maternal EGK report, we can sort of email this out at national level, which includes all of the provinces and districts, or at provincial level, which will include all of the districts within that province. And essentially, we've got 2 pages on the maternal EGK report. The one is the volume of testing that's done, as well as suppression rates at the antenatal, delivery, postnatal, other, and total groups. So you can see that this is for January 2023. I'm going to enlarge it just so that it's more visible for everyone. So you can see that in January there was a total of 14,000 viral load tests done with these EGK codes, which is a lot less than the total number of pregnant and breastfeeding patients getting an HIV. But it is improving slowly, as I've indicated. This then is the number of tests less than 1,000, and this is your maternal suppression rate. And this is the number of tests less than 50 and your suppression rate at less than 50. And we've provided the previous month as a comparator just to see where you're going. And we've been doing this so that the individual provinces and districts can monitor their uptake of the EGK code, as well as their maternal suppression. And to support this even more, we've also provided a facility level report of the codes. So you can actually apply a filter, so I'm highlighting that row, applying a filter, and then select the various facilities that you are interested in to see what was the number of codes. So in terms of, you know, busy maternity units, I think Prince Mtsheni is the busiest in the country. For January, they only had 83 CH-PM TCT codes and only 34 CH delivery codes. So they're obviously underutilizing the codes. But this report was designed to try and improve the uptake of the codes. So that's the one report that we have, and we can add you on to this mailing list should you wish. I mean, it doesn't have any patient identifying data, and it's emailed manually by our team at NICD. The other report comprises a few other chapters. So we have the maternal EGK codes here, which is identical to the maternal report, but we've also got an EID and a viral load sheet. And I'm just going to touch on this very quickly. So in this report, we've tried to break down the age groups as per the DHIS age groups for birth, which is defined as 0 to 6 weeks, and then 10 weeks, which is defined as 6 weeks to less than 4 months. And then there is no DHIS indicator for 6 months, so we've created our own 4 months to less than 8 months, and then the postnatal period. And what we've done for EID is provided the number of PCR testing done, as well as a quick proxy for testing coverage. We obviously expect almost all of our patients to be HIV negative at birth, and we require them to come back for PCR testing at 10 weeks. And if they test negative at 10 weeks, they should come back at 6 months for repeat testing. So your volume of testing at birth compared to 10 weeks and 6 months should roughly be the same. And it's not. There's a big sort of decrease. So the testing volumes that we have at national level at 10 weeks of age is only about 76% of the testing volumes at birth. And we believe our birth testing coverage is well above 95%. Okay, so there's a big gap there. And then there's an even bigger drop, or actually a roughly equivalent drop, between the 10 weeks and the 6 month test, where only about half of the volume of testing done at 6 months has been done at birth. Now this is a rough proxy. We haven't cohorted this, but it gives us an idea of the drop in testing, and it speaks primarily to integration of services, because we don't believe that 50% of the patients leave the country. We believe that a lot of our patients are coming back for EPI services at 10 weeks and 6 months, specifically the Hexa-2 and the measles vaccines, but often they're not being offered HIV testing, and that may be because they're coming to the clinics with caregivers other than their biological parents, and then that's one of the reasons or potential reasons for poor or lack of integration of services between EPI and EID. But this just highlights that and the need to try and improve. Most weaning happens by 6 months of age. So if we can get the testing coverage right at 6 months of age and improve the 10-week test, we should essentially improve early diagnosis. And early diagnosis with linkage to care and initiation of therapy obviously is associated with a decreased morbidity and mortality for our patients, provided that they stay in care. And I do understand that we do have really big challenges with ensuring that our pediatric patients, especially those diagnosed early and initiated on therapy, are retained in care. PCR positives is the number of test positives, and then number of patients first positive is our attempt at deduplicating using that algorithm. It's not perfect. Again, this is probably a slightly inflated number, but at least it gives you a rough approximate of the true number of patients diagnosed as PCR positive versus tested. Okay, so that's the EID component. Just in terms of a snapshot of what is happening in EID for 2022. So we did approximately around 600,000 HIV PCR tests for the year. We diagnosed around 6,500 patients. You can see the testing volumes over here. So the coverage at 10 weeks was around 79% for that whole year, and at 6 months was around 67%. It's nice to see that the 6 month testing coverage has actually been improving quite a lot, because it was only introduced in 2019 or the end of 2019, and despite the pandemic, it has been improving. But we do need to improve the coverage of testing at 10 weeks and 6 months. And then in terms of where the positives are happening, you can see that at birth, actually the highest number per age category are actually being diagnosed at birth, which is really important to highlight, because a lot of the models have been telling us that the majority of infections are happening postnatally, which may be true. I mean, we believe that around half of all of sort of infections in the infant and early childhood periods are happening postnatally, but unlikely to be more than 50% in South Africa. We believe around 30% are actually intrauterine. And the important thing is that they can be identified at birth, initiated at therapy as well, very soon after delivery. And then around 20% are intrapartum, we believe. But this is the mix that we have within the limitations of a linking algorithm, which tends to overlink rather than underlink. Okay, so suppression rates at birth, I'm comfortable with that. It's around 0.7%. But overall, mother-to-child transmission rates in the infancy and early childhood periods, it's probably somewhere around 2-3%. Okay, so it has been coming down steadily. When I started working at an ICD around 2015, we were having about 10,000 patients who were testing positive each year. Now it's down to around 6,500. Okay, so that is the EID component, and I think I've just got a few more minutes. I'm going to quickly go on to the viral load component. So on the sheet of, I'm going to go back to my report over here. That's not that one. It's over here. We've got we've got a viral load sheet as well, which is the age disaggregated viral loads done and viral load suppression rates. Again, we've provided suppression rates at less than 1,000 and less than 50. And this is January for this year. This is this report. We've provided the age and 5-year age buckets until sort of for the end of youth, as well as the peds versus adult DHIS classification of less than 15 and more than 15. And if you just focus on that, I just want to highlight a very important point that if you look at suppression rates at the less than 1,000 cutoff, comparing the less than 15 with the greater than 15, the pediatric suppression rate is a lot lower than the overall program for this month. This is January, which obviously month-to-month fluctuations, we provided the same month of the previous year, that's last year, but we've also provided data for a rolling 12-month period where you can really get a good idea of what is happening with the pediatric and adolescent programs compared to the adult programs. I'm going to focus on that here. So this is rolling 12-month data, and if you look at the percentage suppressed in the less than 5-year age group, only 63% of patients less than 5 years of age last year had a viral load of less than 1,000, and that's their last viral load for that year period. And if you look at suppression at less than 50, it's only 40% of our children less than 5 years. And this is a sort of tip of the iceberg, right? Because these children were diagnosed, they were linked to care, they were initiated with therapy, they are being monitored with a viral load, and only 40% are actually suppressed. And if you look at age as it increases, you can see that the suppression rates increase as well. And that's an important principle, because although our PEDS population is a lot smaller than all the other age groups, they're not doing well. And the numbers are, I think, reasonable to expect that we can hopefully address this effectively. And I know there's obviously quite a lot in the pipeline in terms of supporting and improving pediatric HIV. And our job is obviously to help with the monitoring component of that. Okay, so that's the viral loads done and viral load suppression. And I'm just going to quickly go through this. Lisepa, I'm hoping you're going to stop me if I need to be stopped in time. Otherwise, I'm going to carry on for 2 minutes. All right. Okay, you can probably hear me. I'm talking far too quickly. All right. So this is that principle that I've just sort of shown in terms of the younger age groups being associated with a lower proportion of virological suppression. So this is for the country. This is for last year, the whole of last year, 2022. And I've provided the volume of viral load testing per 5-year age group going up to the end of youth. Obviously, the less than 5s comprise the smallest population because of an effective PMTCT program. But despite that, you've obviously got a very, let's say, high number of patients who require attention because they are not suppressed. And it goes up with increasing age, but obviously the number of patients who are living with HIV obviously increases as well as the absolute number who are not suppressed in the older age groups. This is just something interesting that we found with the data, and that is, we get asked to disaggregate the data males versus females, especially at the older adolescent groups and the youth groups, because the idea is that adolescent boys are a lot more difficult to treat than adolescent girls, and obviously there is a much bigger drop in terms of the number of adolescent boys living with HIV proportionately who are accessing care versus adolescent girls who although they represent a much bigger burden in terms of the overall population living with HIV, but actually suppression rates are most different in the infancy period between males and females. So suppression rates for females is in pink, suppression rates for males is in blue, and you can see that the difference in the less than 1 year age group is actually the largest. It's about 10% difference, and that is something that has interested me. I haven't had the time, I'm afraid, to explore this further, but I think it's fascinating, and maybe there's an immunological basis for this difference. And again, I haven't had the time to look into it, but I think it's something that should be investigated further. And you can see that even sort of the 1 to 4 year olds, there's a big difference between female suppression rates and male suppression rates. And I'm assuming it isn't a sociological issue, but it is something that is really curious. And then we do have this big difference again in the older adolescents. It's just something that our data can support in terms of further monitoring. The other thing I'd like to bring to the audience's attention is that, in terms of pediatric suppression, I think I've clearly demonstrated we're not doing well. But I think the most concerning thing for me is we're actually getting worse. So I've broken down the peds and adolescent and youth age groups in these 5-year age bands and looked at rolling 12-month data for the past 5 years. And if you look at sort of at the top, this is the 20 to 24 year age group. Okay, nothing much has really changed. Around 83% of patients have a viral load of less than 1,000 in the youth age group 20 to 24. There's been slight improvement in the 10 to 14, which is in gray, and the 15 to 19. But if you look at our youngest populations, the less than 5 and the 5 to 9, it's kind of flatlined. And then actually over the past 12 months, it's actually been getting worse by around 3%. So suppression dropped for the less than 5 year age group over the past year from around 65% to around 63%. And again, for the 5 to 9 age group, it dropped from around 77% to around 75%. So we are going in the wrong direction with pediatric HIV control. And this is just looking at suppression rates per province. Again, there's quite a lot of variability across the provinces, with some provinces performing sort of, markedly better than others, but still across the whole country, pediatric patients prove to be, let's say, very challenging with regards to achieving sort of high proportions of suppression within the program. So this is, I think, one of my last slides. This is just looking at the overall cascade for South Africa. So I went from really patient level data through to sort of, a very bird's eye view snapshot of how we're doing in terms of the 95 cascades. So this is a combination of Tembisa 4.5 data with the NHLS data coming from NICD. So this is, the number of people living with HIV currently in South Africa. We have around 7.9 million people according to the model, of which around 93–94% know their status according to Tembisa, and then according to Tembisa, around 5.5 million are on ART. And now the last two columns we've got here is the actual laboratory data, which it's quite reassuring that the viral loads done, and this is deduplicated to represent patients, is very close to the actual model on ART data. It represents, if you look at the proportion of patients with a viral load who are knowing their status, it's around 74%. So there's obviously a bigger drop between the first 95, which is know your status, to the second 95, which is get on ART. And then the last column here is the actual viral load suppression at the less than 1,000. And as I mentioned, we're sitting at around 91% of all patients within the program have a viral load of less than 1,000, and that is very different, across the various age groups. So here's looking at sort of rolling 12-month data from September for each year. So it's pretty much as good as five years worth of data. Each data point represents 12 months of data, and this is the suppression rates for the overall program, going up from around 87-88% in September 2018 to around 90% in September 2022. And as I've indicated, it's just gone above that now. But this is where female patients sit in terms of suppression rates. They obviously are better suppressed than average, with around 91% of our patients who are female are suppressed. This is where males sit, around 88%. Again, there has been improvement in both the females and males over the past 5 years, although they seem to be flatlining a little bit over the past 12 months. This is where adolescent girls and young women sit. So this is 15 to less than 25 female patients, sitting at around 82%. This is where adolescent boys and young men sit, with suppression rates of around 76%. And this is where the pediatric population of less than 15 sit at a suppression rate of 73%. Again, suppression at less than 1,000. And that's my talk. I do have, obviously some additional slides if there's time and questions that relate to those, but just in terms of the summary. So I've touched on the patient identifying results for action reports, which we believe are a powerful tool that enables us to act early on elevated viral loads or positive PCRs on individual patients. And the idea behind that is to try and sort of support access to this important data so that it can actually improve outcomes. Obviously they need to be used efficiently within we believe facilities to optimize their utilization, specifically with regards to tracking and tracing. But because they contain sensitive information, all precautions need to be taken to safeguard patient confidentiality and ensure that you utilize the data in a legal and POPI Act compliant manner. And then just to mention that we do have other data that we provide to support programmatic monitoring, such as this use of the EGK code for maternal monitoring. And with that, I will thank you all very, very much for listening and spending an hour of your Thursday evening with me.
Yes, Ahmad, that was a very, very, very loaded presentation. Inspiring, but I think equally or probably more than that, challenging, on some of the data that you have shared. Colleagues, I'm hoping you have seen why the lab interface, is so important, and why this information, you need to have access to it, because you might be seeing patients every day. You can count your ones and twos, but you might fail to see, the impact on the program. And also, if you are having a clinic that's very busy and taking, 500 viral loads every week, how do you know, which ones are suppressed, not suppressed, which ones we need to trace and track, And from my side, I think some of the key, takeaways, the whole thing around, pregnant women who are not suppressed, and at delivery, I think it's a huge concern. The drop-offs in PCRs, comparing delivery, 10 weeks, 6 months, it's huge. Then I almost cried, Ahmad, when I saw about 600 positive PCRs. I think it was January, but it was 1 month. I almost cried. I was like, no, because you see, HIV is preventable, but they're not incurable. So, we have to do a lot to ensure that no baby is born with HIV. Then when you showed the annualized version, 6,000 babies, colleagues, 6,000 babies born with HIV in 1 year. It's a lot of babies. And I used to celebrate the 1%, Ahmad. You know, when we moved from whatever, 20%, 10%, I used to say, yo, 1% we are winning. No, we are not winning at 1% because 1% in raw numbers, it's 6,000 babies every single year who are born with HIV, and they would live with it for the rest of their lives. So I didn't like that slide. I don't know, you know. And then when you got to the children, issues of adolescence, and then you got to the males, then you got to the boys, then I realized, okay, there is a lot of challenges and issues that we have to really deal with. Before we go into the discussions, there was a number of questions around people asking how do they register and access the reports. I think it's people who missed the first few minutes, I think, of your presentation. So colleagues, do check out our YouTube channel. I will share the recording there. I will ask as well Ahmad to share his slides, and then if there are no consent issues, we will distribute the PDF version of the slides. There's a nice process and documents. I'm sure you can also share some of the PDFs, Ahmed, which I can share with the slides, which Definitely. Can be helpful for people to understand. All right, so yeah, colleagues, I'm going to allow you to raise your hands. Those of you who would like to ask questions, we have some time for questions at least until past. So we have like 15 minutes, Ahmad. So this is good. So one of the questions, Ahmad, I don't know, you know, who is responsible? I don't know if you are the right person to answer this question, but you let me know. Who is responsible for tracking and actioning? For me, these reports seem mandatory, that they should be accessed by everyone who's working within the public health system. But someone was saying in my district, province, people are not tracking or people are not actioning. Do you know who is best suited to really track and act on these reports?
So yeah, no, that's a great question. So I mean, initially it has been spearheaded in terms of the utilization by the district support partners, and they've been utilizing the reports, I think, and taking the lead in that. The utilization of the RFAs is part of the 2019 guidelines, and it's also part of the pediatric matrix of intervention. And because of that, we have been getting more and more traction within the Department of Health, and we've been trying to actually focus getting facility level usage within the Department of Health structures. So yeah, we're getting there. We occasionally get invited to provide workshops within the Department of Health, whether that's national or provincial or even district, and support with the training. So I can show you. I mean, we've just been doing trainings in KZN towards the end of last year. We managed to train about 1,500 staff, of which 300 were clinical staff, and this was data for action training arranged by the M&E team in KZN. And we went through the trainings, and we certainly have seen sort of some traction. So this is at district level report for KZN. Their subscriptions went from 238 district level reports to 357 reports subscriptions, and this is broken down per district. At facility level, it jumped even more because, as I mentioned, the reports are available at district level as well as facility level. So the number of facility subscriptions increased from 731 to 1,200. But obviously, we don't just want people to subscribe. We actually want people to utilize the data. So we're able to monitor how many people are actually downloading the reports as well. And it increased from 32 people within the province, and that includes all reports, whether it's district or facility, and it peaked at 97 users within a given week. So this is calendar week 32. It goes through, our numbering is a little bit different. So we have a calendar week 53 where the year ends. But just to highlight what's important is over the holiday period, the utilization went down. And I think that is cause for concern. I'm not sure if we compromise patient care over the holiday period, but that's what we saw. There was certainly an improvement in downloads with these trainings within the Department of Health structures. But yeah, it's available to anyone within the public health sector, essentially.
Superb. And today, at least you've reached some 300 people. I hope colleagues will go and register and really use the reports. There's a question about what is the contribution of breastfeeding to the transmission in the PMTCT program.
Yeah.
But I was actually shocked to see that a huge proportion of positive PCRs are from the delivery viral loads. Reflecting maybe some antenatal issues that we are failing to address. But because of your follow-ups, Ahmad, with the follow-up PCRs, don't you think that if the coverage was good, we could then see the true reflection, and maybe we do have a higher postnatal transmission versus the delivery or intrauterine transmissions? Yeah,
it's possible. I think quite a lot of the patients that we are detecting at around 6 months actually have already been diagnosed. We have a problem with linkage of care, and that's partly why we're providing these results for action, because we see patients who test positive. Some of them never come back in terms of being linked to care and then pop up later. Some of them are repeatedly tested and never linked to care. And we see this often as well, where a patient or a caregiver will get a positive result and they don't want a positive result, and they'll go to another facility and they'll go to another facility. We have patients who have 5 positive PCRs, and that's really not a good thing, because it suggests that patient has not been linked to care. And again, you should be able to see these patients on the RFA reports and hopefully bring them into care. There's obviously the incident HIV infections, and yes, that is going to happen and contribute. And then there's migrants as well that were never tested. But I think it's really difficult to flesh this out. But yeah, our hunch still is that probably up to about 50% postnatal infections in South Africa, that is.
Yeah, and okay, yeah. So I think that is fine. So with regards to suppression, I thought I should leave it to you to clarify. When we say suppression, do we mean less than 50 or less than 8,000?
Yeah, or less than 400, because we also cheered on that and used 400. Yes. So it depends who you ask and what you're using the data for. So in terms of clinical management, suppression is less than 50. Yes. In terms of monitoring, where we look at the UNAIDS targets and cascades of 90-90-90, or what's now referred to as the 95-95-95. So obviously we need to talk the same language across the globe in terms of what are we actually monitoring. So this 95 cascade defines suppression at less than 1,000. Okay, some regions in the country only use less than 1,000 as suppression, because in South Africa we know that a low-level viremia is clinically relevant. We obviously have this less than 50 cutoff, but for the agencies that we report to and monitor and compare, the suppression is usually cut as 1,000. So I think the question is, if you are seeing a patient, suppression is less than 50. If you are sort of reporting to UNAIDS, suppression is less than 1,000.
Yeah, and I think as a country, I think the Department of Health was not very confident to shift it at a program level, to less than 50, because then we would have to respond to huge populations of patients, some of which are even taking treatments outside of facilities. But the upcoming guidelines, once signed off, there is that shift to even define suppression by 50 copies per mil. So I think that's going to change a lot. Now, there was a question, a comment, and we'll come back to the questions. Someone when I think it's Dr. Tsietsi, I think he was saying this present, especially the first part where you're talking registration and stuff, you are saying it should be introduced at medical school, because so that when people start working, they already have access to the system. And he was reflecting on his own experience and difficulties using the system when he was already, working. Would you like to comment about the impact that can have on the program?
Yeah, I think that is a great point, and I think also it could really be very valuable in induction training for junior doctors as well. I think probably more so because things will change as you go through medical school. But for induction, when you sort of internship and community service, I think it would be very valuable. I think to get the platform is a challenge, and I think if we get those invitations. We'll try our best to support the trainings, bearing in mind that we are an extremely small team. But yeah, I do agree. I would really like to get this information out there where it can actually be of relevance and support.
Superb. Let's hear a voice or a live comment or question. Ray Motla, would you like to unmute? Ray Motla, please unmute if you...
Yes,
thank you.
I'm with you. I'm wondering if we could maybe compensate for the lack of birth viral loads at the 3-day visit for the maternal and perinatal care for the purpose of continuing care.
Thanks for that comment. Yeah, yes, absolutely. There was actually a circular from Department of Health saying that if a patient hasn't had the CHASH delivery code and viral load done at delivery, you can do the viral load and use that code up to 6 weeks post delivery. So definitely, if the viral load isn't done. Look, I mean, in terms of clinical management, the ideal would be to have the viral load results before discharge, and that isn't going to happen for a lot of our patients. But the guidelines have remained that we believe that a test at time of delivery is important, because you should be able to get that result on day 3 to 6 postnatally. But if no viral load was done and that patient is following up postnatally, please do the viral load at that juncture. Essentially, the viral load should be used not just to inform the mother's care, but also the infant, because you need to categorize if this patient is high risk or low risk. The PMTCT guidelines are I'm not sure if they were released yet, but they have revised what high risk and low risk is. And essentially, if a patient or an infant doesn't have their mother's viral load available at discharge, all patients should be on high risk prophylaxis, essentially, until that viral load is obtained.
Thanks, Ahmad. So Ahmad, on the administration side, if a person has access to one type of report and they would like to access other reports, because I see Mahohori, I think she works with the National Department of Health. She's saying, I only have access to the PCRs. How do I get viral loads? But I've also seen someone who says, I only receive viral loads. How do I get the other tests? It means they are registered. I wonder if some people, they were helped to register by someone else, and maybe they're just receiving reports without logging in.
Perhaps, I mean, but yes, I mean, if you've got a username and password, you go back to the portal. So you should be getting an email. Excuse me. You should be getting this email if you're registered, and then you're double clicking on the link, or you're going through the NICD dashboard and you're clicking on the RFA portal, right? You can go click on the self-service registration as well. If you click on the self-service registration button, you'll see this screen where you can add report distribution for existing users. And then you simply select add report distribution, and then you'll have to enter your ID number or passport, run the document, and then you can add a report by facility or by district or by province. And then you go through the necessary steps in terms of selecting what category report you want, what's the name of the report, do you want it daily or weekly, and where do you want it for. I'm going to share the slides, and there is within each of these slides that there is an embedded basically PDF which is a job aid to support access and utilization. Also, on the weekly emails, there is a user guide for the RFA distribution that you can select as well.
Yeah, yeah.
And if any queries, sorry, you please just send us an email at hiv@nicd.ac.za.
Cool, cool. There's a related question, and I see the question coming back again. So maybe we should deal with it. Someone is asking if they improve the supply of addresses or phone numbers. Is there a retrospective way of updating all the previous records, basically?
It's a good question, but yeah, potentially yes and no. So we've got the laboratory information system, which is TrackCare. Okay, TrackCare is going to have individual results associated with particular address and contact details. That's never going to be updated. But within the data warehouse environment, we've got a bit more, let's say, flexibility in terms of linking and updating. So it's something that I had right at the end of my presentation, which I wasn't sure if I was going to actually mention or not. But the next step to these results for action reports is actually a live dashboard, which we are currently piloting, because we know that working with Excel spreadsheets is cumbersome. And what we really want is a way of updating the information in a near real-time way, so that the whole field can see which patients actually still require action, which patients need tracing, which patients sort of, need follow-up. And to do that, we've created an online dashboard, which looks like a results for action report, but it can accommodate clinical outcomes as well. And the idea why we're doing this is we don't want to replace Tier.net, but because Tier.net is limited to a particular facility, we want a way of viewing, especially at least at a district level, of seeing which patients in your district who were diagnosed actually haven't been linked to care, which ones aren't suppressed. And to do that, we're basically piloting this dashboard, and you can update the patient's details on this dashboard so that the information is there and their latest contact information can be obtained. So yeah, we have been sort of working in the field, and people using the RFAs have reported back that this is kind of what they want. So we've developed this, we're piloting it, and the nice thing is there's also automatic analytics as well, because if you can provide the outcomes, then you can see what proportion of your patients sort of haven't been linked to care or not suppressed or have an overdue viral load, or who have virological failure or repeatedly high viral loads. So that's what we are currently working on.
Colleagues, lots of innovations. Oh yeah, it's exactly 1:30. I was about to continue, but I think I have a question. Yeah, colleagues, just one more question. Just to ask, on the patient side, is there a plan to start to involve the clients even more, getting alerts that it might not be specific, I don't know if there's laws around that, to say, hey, one of your recent blood results, the results are ready or they're abnormal. I'm not sure what would be a relevant message, but is there a way to now direct automated, alerts direct to via SMS or email, even for health? Yeah.
I believe that there is, and I believe the NHLS had been using that, and actually had been using it with COVID. And so obviously, that there is scope and potential. That program runs off the laboratory information system rather than the data warehouse, as far as I'm aware. So it's not something that we're working on, but I do think there's scope, and I think in principle we need to sort of empower patients to basically, be able to take responsibility for their health, and I think having that information is really important. Again, it's not something I'm working on, but I do believe that there is scope for that, and hopefully other teams on the ground are.
Superb. Ahmed, thank you. Colleagues, thank you very much for joining us this evening. Ahmed, maybe your take-home message to the audience as we close?
Oh, just have a good evening. Thank you very much for joining, and thank you for your interest. It's really appreciated. Thanks for the opportunity, Lisa.